Good morning, doctors. I am John Erico Pabustan, a second-year medical resident from James L. Gordon Memorial Hospital, presenting a case of Guilla Barre Syndrome, Miller-Fisher variant with our consultant, Dr. Arturo Martin Arconcel. The objective of today's presentation is to present a case of a 51-year-old female with Miller-Fisher Syndrome and to discuss the pathogenesis, clinical presentation, diagnosis, management, and prognosis of the disease. This is a case of a 51-year-old female, housewife, Roman Catholic, married, a resident of Castillejo, Zambales, admitted for the first time in our institution. The chief complaint of the patient is inability to open mouth. The history of present illness started one day prior to admission, wherein the patient noted difficulty in opening mouth during speaking and eating, accompanied by dysphagia to both solid and liquid. There was no accompanying abdominal pain, vomiting, diarrhea, symptoms of pneumonia, headache, loss of consciousness, nor wound. There was also no difficulty in moving, opening, and closing both eyes, no weakness on the bilateral upper and lower extremities, as well as the trunk. Consultation was done with a private doctor, wherein the blood pressure was noted to be elevated at 160/90 mm mercury and was advised admission. Patient was also given aspirin, cilostazol, atorvastatin, and tan. Few hours prior to admission, there was a noted progression from the difficulty to now inability to open mouth and purse lips. There is also an increase in the severity of the dysphagia and now unable to fully close both eyes and do facial expressions. This prompted consult to the emergency room, hence admission in our institution. For the past medical history, the patient is a known hypertensive since year 2000 with no maintenance medication. Patient's mother is hypertensive. Patient is a non-smoker, non-alcoholic beverage drinker, and a non-illicit drug user who lives in a bungalow house together with her son and husband. The patient is Gravida 2, Para 2, 2002, and was menopaused at 8. Coitarch of the patient is at 25 years old with one sexual partner and no history of OCP use. The review of systems of the patient is remarkable. For the physical examination, the patient is ambulatory, conscious, coherent, ectomorph, and is not in respiratory distress. The vital signs of the patient is at 130/80 mm mercury, tachycardic, tachypnic, afebrile, with good oxygen saturation and a BMI of 19. The skin and the head, ears, eyes, nose, throat examination was unremarkable. The chest, heart, abdominal, and extremities physical examination were unremarkable. For the neurologic examination, all the cranial nerves were normal except for cranial nerve 7. The patient is unable to move forehead muscles, unable to fully close eyes, unable to move nostrils, smile, purse lips, and open mouth. The cerebrum, the motor, the cerebellar, the sensory, as well as the meningeal signs were unremarkable. There was a noted areflexia on bilateral lower extremities. Babinski reflex is negative. For the salient features of the case, I am presenting a 51-year-old female with inability to open mouth accompanied by dysphagia. There was sudden onset of symptoms with no prodrome. Patient is a known hypertensive. The blood pressure of the patient was 130/80 mm mercury with inability to fully close eyes, purse lips, and do facial expressions. There was also noted areflexia on bilateral lower extremities. The admitting diagnosis is to consider Guilla Barre Syndrome, Miller-Fisher variant, rule out tetanus infection, stage 2 hypertension controlled. At the ER level, patient is still unable to open mouth with the same objective findings. Patient was inserted with nasogastric tube at 1,500 kilocalories in 6 equal feedings, hydrated with plain NSS, and requested with basic laboratories, including 2D echocardiography, EMG, and lumbar puncture. Patient was started on methylprednisolone 1 gram per IV to run for 4 hours once a day. Benzylpenicillin 3 million units per IV every 4 hours. Baclofen 5 mg per tablet, 1 tablet every 8 hours. As well as omeprazole, losartan, aspirin, and statin. The chest X-ray of the patient revealed clear lung fields with normal heart size, atherosclerotic aorta, with intact diaphragm and thoracic. The patient had an unremarkable complete blood count. The patient's fasting blood sugar is elevated at 9.25 with a normal glycosylated hemoglobin. The cholesterol of the patient is also elevated at 5.82. The urine flow cytometry of the patient is unusual. The patient's 12-lead ECG revealed normal sinus rhythm with interventricular conduction. The 2D echocardiography of the patient revealed a normal left ventricle with normal systolic function and grade 1 diastolic dysfunction. There was aortic valve and mitral valve sclerosis with an atheromatous aorta. For the lumbar puncture of the patient, it revealed a 1 cc colorless alkaline CSF with no WBC nor RBC. There was also an elevated total protein at 2.02 grams per liter. The decrease to no WBC and the presence of an increased protein is what we call albuminocytologic dissociation. For the course in the ward, on the first hospital day, patient is still unable to open mouth and swallow. The BP is at 140/70 mm mercury and still unable to do facial expressions. There was still areflexia on bilateral lower extremities. The patient is still for EMV and CV studies, with RBS monitoring stable at 104 to 123. On the second to third hospital day, patient is now able to open mouth and swallow, able to fully close eyes, clench teeth, purse lips, and do facial expressions, with a noted improvement on the reflex from areflexia to hyporeflexia on bilateral lower extremities. Patient, however, is still for EMG studies. For the EMG and CV studies of the patient, it showed temporal dispersion on both sides with reduced amplitudes and showing blink reflexes that are reduced to absent on the right. Needle evaluation of the left orbicularis oris and frontalis muscles showed widespread polyphasic potentials, fast-firing recruitment pattern at poor to submaximal in effort. The left nasalis muscle showed decreased motor unit amplitude, widespread polyphasic potentials, reduced and fast-firing recruitment, and decreased interference pattern. This electrophysiologic study is consistent with the clinical impression of acute idiopathic demyelinating polyneuropathy, Miller-Fisher syndrome. On the 4th to 7th hospital day, patient was put in progressive diet. Patient's methylprednisolone was finished up to day 5 and benzylpenicillin was finished up to day 7. The final diagnosis for this patient is Guilla Barre Syndrome, Miller-Fisher variant, stage 2 hypertension, controlled. For the discussion, Miller-Fisher variant has been estimated at 0.09 cases per 100,000 persons per year. The incidence is 1 to 5% in Western countries and considerably higher in Eastern Asia. It occurs more frequently with men, with a ratio of 2:1. The median age of onset is 44 years old, with two peaks of distribution at 30 to 39 years old and 50 to 59 years old. The clinical presentation was originally described by Miller-Fisher in 1956. It is a rare immune-mediated neuropathy characterized by a triad of external ophthalmoplegia, cerebellar ataxia, and the absence of tendon reflexes. Other cranial nerves such as the facial nerve may also be affected. It is usually preceded by an upper respiratory tract or a gastrointestinal tract infection. It is an unusual variant of GBS because half of the patients diagnosed progresses to it. The most common agents include Campylobacter jejuni, H. influenza, Mycoplasma pneumonia, cytomegalovirus, and Epstein. For the clinical presentation, the most common initial symptom is diplopia with bilateral extraocular muscle weakness. Facial nerve involvement may be present as lagophthalmos, in which the patient may not be able to fully close the eyes. The most predominant symptom is an ataxic gait. The motor strength is usually preserved. The median time from the infection onset to development of neurological symptoms is approximately 10 days. It follows a self-limiting course wherein the majority of the patients usually have complete resolution on an average of 10 weeks. The recovery of the ophthalmoplegia and ataxia usually starts by day 32 and is complete by the first year. A general rule on GBS is a 4-week course that reaches a state of nadir, the peak weakness of 10 to 14 days, then a usual complete recovery within the next 6 months. It can rarely become recurrent. However, it may progress to respiratory failure and require mechanical ventilation in children. Worst case scenario is tetraplegia in 24 hours with incomplete recovery within weeks. Differential diagnosis for this case include ocular myasthenia gravis. However, in this condition, the diplopia and ptosis worsens during the day, and there is a characteristic Cogan's lid twitch. Another differential diagnosis is Bickerstaff's brainstem encephalitis. However, this condition presents with pyramidal weakness and sensory loss, together with altered level of consciousness, both of which are not present in our patient. Another differential diagnosis is Wernicke's encephalopathy. The patient usually is a heavy alcoholic beverage drinker and usually presents with nystagmus, which is both not present in our patient. Brainstem infarct or hemorrhage can also be ruled out because there is no pyramidal weakness present in our patient. This is a representative picture of a nerve cell. The cell body on the left with the connecting axon towards the postsynaptic cell. An action potential usually reaches one cell body towards the postsynaptic cell through saltatory conduction, and this is possible through the presence of nodes of Ranvier. This is a diagram involving the complement cascade. We focus our attention on the classical pathway, wherein the antigen and antibody complexes from the molecular mimicry from the infectious agent and the body's GQ1B gangliosides activate an immunologic attack on the axolemma. It involves C1, C2, and C4. It then activates C3 and C3 convertase to activate C5 and C5 convertase, forming C5b. This C5b will then form the membrane attack complex composed of C5b, C6, C7, C8, and C9, and this produces destruction of the cell. The activation of complement and deposition of the membrane attack complex on the ganglioside antigens found on Schwann cell membranes expressed on the axolemma produces recruitment of the inflammatory cells, opsonization, uptake, killing, and perforation of cell membranes on the Schwann cells. This leads to nerve conduction block and eventually axonal degeneration, found in Guilla Barre Syndrome. Among clinical variants, each has a predilection for autoantibody formation against different glycolipids within the ganglioside family, such as GQ1B, GM1, GM2, GD1B, GD3, and GT1A. The GQ1B ganglioside complex is the most often involved in Miller-Fisher syndrome. Ophthalmoplegia can be explained by dense concentrations of GQ1B gangliosides in cranial nerves 3, 4, and 6 that cross-reacts with anti-GQ1B antibodies, producing the weakness. Ataxia happens because there is selective involvement of 1A afferent neurons along their path from muscle spindles to the spinal cord. Areflexia happens due to the discontinuity of the reflex arc from the peripheral nerve to the lower motor neuron. Ataxia can be defined as unsteady gait with inability to walk heel to toe. Areflexia does not usually affect the patient's ADLs. For the diagnostics, the cerebrospinal fluid analysis usually shows an elevated protein with no WBC and RBC. Miller-Fisher syndrome still remains a diagnosis made primarily from clinical history and physical examination. However, this CSF analysis can be helpful in clinching such diagnosis when there is this characteristic presence of albuminocytologic dissociation. For the EMG-NCV findings, electromyographic findings include abnormal motor recruitment, decreased recruitment, and rapid weak firing of motor units. Nerve conduction velocity studies include delayed distal latency with slowing of the NCV and temporal dispersion waveforms together with absent F and H waves. These NCV findings is usually congruent to demyelination. Sensory abnormalities are usually exhibited by most with sural sparing. EMG-NCV studies in acute GBS may be normal and may take even 3 weeks to develop. The anti-GQ1B antibody has a high specificity and sensitivity for the Miller-Fisher syndrome. It is usually found in neural tissues such as peripheral nerves and the brain. treatment for the standard of care for Guilla Barre Syndrome is immunotherapy. There are two types of immunotherapy: plasmapheresis and intravenous immunoglobulin. Plasmapheresis is a process in which extracorporeal separation of blood components results in a filtered plasma product using centrifugation or semi-permeable membranes. Just like dialysis, plasma is separated from RBCs of the patient, resulting in a filtered plasma free of antibodies. Albumin was found to be more beneficial than fresh frozen plasma as a replacement to the patient. A study published last 2002 revealed that plasma exchange or plasmapheresis is the first treatment proven superior to supportive therapy for GBS. Continuous plasma flow exchange is better than an intermittent one and is most beneficial when started within 7 days of the disease up to 30 days. A mild disease usually requires 2 sessions and moderate to severe disease usually requires 4 sessions. If the patient's symptoms is within 4 weeks of non-ambulance, patient is suggested to have plasma. The recommended parameter for plasmapheresis is 1 plasma volume, usually 50 ml per kilogram, for 1 to 2 weeks. Complications of plasma exchange include hypotension, septicemia, pneumonia, abnormal clotting, and hypocalcemia. An alternative to plasma exchange is immunoadsorption therapy, wherein there is no need to replace the immunoglobulins with albumin or fresh frozen plasma. Another therapy used is intravenous immunoglobulin. IVIGs are sterile IgG products from pooled human plasma. The immunosuppressive effect is mediated by IgG's Fc glycosylation. Usually, 95% of unmodified IgGs with trace IgA or IgM from 1,000 or more blood donors. When antigens bind, it increases the expression of the inhibitory Fc receptor, leading to glycosylation, shortening the half-life of autoreactive antibodies. Other mechanisms of IVIGs include immune complex interactions with Fc receptors on dendritic cells, which then mediates anti-inflammatory effects. The complement system leads to enhanced removal of all antibodies, especially the autoreactive ones. There is direct suppression of antibodies and macrophages. And the newest mechanism of action is the decrease in activation of microglia due to tumor necrosis factor A and interleukin-10, thereby decreasing inflammation. In simplest of terms, IVIGs fill the system with antibodies in order for the body to stop producing autoantibodies harmful for the body. IVIG is found to be as effective as plasmapheresis. The recommended dose is 0.4 grams per kilogram body weight daily for 5 consecutive days. Due to the convenience and availability, it replaced the plasma exchange in most treatment facilities. The usual cost, however, is 70 to 100,000 per day on a standard 50 kilogram standard body weight. A patient that is on 2 weeks non-ambulance is usually required to do IVIG. IVIG slightly hastened ophthalmoplegia and ataxia on one particular study on Miller-Fisher syndrome. Both IVIGs and plasmapheresis did not, however, influence overall outcomes. Due to the good natural recovery of the disease, mild cases may be treated conservatively. Moderate to severe cases must be treated with immunotherapy. Supportive care is also important for measures. Nutrition provided by nasogastric tube feeding must be done. High energy diet around 40 to 45 non-protein kilocalorie. High protein diet of 2 to 2.5 grams per kilogram. And continuous enteral feeding is better tolerated than bolus feeding. NGTs are usually inserted because there is usually involvement of bulbar muscles. High protein diet is advocated to prevent muscle wasting and assist respiratory weaning. Physical therapy must be done, such as active range of motion exercises if tolerated by the patient. Passive range of motion exercises is done to prevent muscle atrophy if not able to tolerate the active range of motion. Gait training, such as use of canes, walkers, and crutches, as well as self-ambulation, must also be taught to the patient. Activities of self-care to fulfill activities of daily living and to address the resultant dysphagia and dysarthria by speech and swallowing exercises must be done by an occupationist. DVT prophylaxis, such as heparin and compression support stockings, are also advocated. GBS is the most common peripheral neuropathy causing respiratory paralysis. Mechanical ventilation is needed if there is an impending respiratory failure, such as tachypnea and tachycardia, asynchronous movements of chest and abdomen, as well as early predictors such as vital capacity less than 20 ml per kilogram, maximal inspiratory pressure of less than 30 mm water, and maximal expiratory pressure of less than 40 cm water. Early predictors for respiratory failure include facial or neck weakness and bulbar paresis. 2 to 6 weeks are needed in order for a patient to be weaned out of ventilatory support. Percutaneous dilatational tracheostomy may be required for patients having mechanical ventilation for greater than 2 weeks. A humanized monoclonal antibody, eculizumab, is one of the novel treatments tested for GBS. Despite the advent of IVIG and plasmapheresis, many patients suffer from incomplete recovery. Eculizumab binds directly to the complement protein C5, inhibiting the formation of membrane attack complexes. These membrane attack complexes has been shown to be on Schwann cell membranes of patients with AIDP that primarily causes membrane disruption, hence long-lasting disability. In a murine model, it effectively prevents respiratory muscle paralysis and motor nerve terminal damage. A study named Safety and Efficacy of Eculizumab in GBS, a multicenter double-blind randomized phase 2 trial, recommends Eculizumab because of its study involving a 4-week treatment of eculizumab 900 mg plus IVIG versus placebo plus IVIG. The main outcome for this study is independent ambulation, with 61% of patients in eculizumab obtaining this outcome and only 45% in the placebo group. For the prognosis, all patients affected will follow a 1/3 rule. 1/3 will fully recover, a third will partially recover, and the last third will not recover. The overall prognosis for GBS is approximately 85%, with these survivors making a good functional recovery. However, those who suffer the sequela have a 20% mortality on mechanically ventilated patients. Factors associated with poorer outcome include patients aged 57 years old and older, those who present with severe weakness at the onset involving the upper extremity, acute hospital stay of greater than 11 days, rapid onset, an ICU requirement due to a high involvement like the bulbar area, muscle wasting, the need for mechanical ventilation, on EMG and CV findings, a finding of inexcitable nerves, and a preceding diarrheal illness. Miller-Fisher syndrome has a better prognosis than other GPS subtypes. A second episode of this disease, however, will render the patient to having a poor prognosis. Relapse happens in 10% of patients after initial improvement. No significant evidence that treatment affects acute relapse. However, risk of relapse involve late treatment, a protracted disease course, and presence of more comorbidities. Thank you very much for listening.